That's where it comes from.
I haven't.
Okay. Good morning, councillors, officers and the viewing public. Welcome to this meeting of the Health and Social Care Overview and Scrutiny Committee. May I remind members that the meeting will be webcast for live or subsequent broadcast via the Council Meetings YouTube site, and that members of the public and press may record and take photographs, except where there are confidential or exempt items. Can I remind officers and guests joining on Teams to please keep their cameras and microphones off unless speaking, and please use the raise hand button if they want to speak. For officers and guests in the room, please speak directly into the microphone. Yes, I can do that myself, to ensure that the live streaming is clearly audible. Apologies. Can I ask both members and the scrutiny officer if there have been any apologies received for the meeting? I haven't received any myself.
No apologies received, Chair.
No apologies. Okay, thank you for that. Declaration of interest. Can I ask members if they have any declarations of interest to make?
I think we've all got an interest at the moment in time, Chairman.
Yeah, I think so. Point taken, that dealt with. Action note matters arising. So first we need to approve the action notes from the meeting on the 22nd of November 22. There's a couple of actions from the 19th of July informal meeting on question 4, which is the Adults and Social Care Performance Monitoring Report, which was to say that a further informal briefing session is to be organised with Andrew Marsh and a representative from the University Hospitals Birmingham NHS Foundation Trust. Scrutiny officers have been in contact with Andrew Marsh to follow up on this request, and we're waiting for some proposed dates. Do you have any update on that, Fiona?
I don't at the moment, Chair.
Okay, thank you for that. Then an action from the 22nd of November meeting regarding the presentation from Birmingham Solihull Integrated Care System regarding the 10-year strategy. It was resolved that a notice provided on what long COVID services are available in Birmingham, and to provide a note on the membership of the ICS Partnership, the ICS Board and the Place Board. This information has been requested with an indication of when it's likely to be available. The last information I had was the scrutiny officers are still awaiting for a response. Has been an update on that? We're still awaiting a response.
Still waiting, yeah.
We're still awaiting a response. Okay.
No, it's a concern at that point. I think we need to know the command and control structure of this organisation, and for obvious current reasons, this is key to us. But we are lacking the reply.
I think you're right, Councillor Percock, certainly with regards to the one from Andrew Marsh and University Hospitals Birmingham, because that was back in July. So that's a significant length of time ago. So could we sort of chase them up?
Certainly, yes. I think the action with Andrew Marsh came from the most recent meeting, though it's been part of an ongoing discussion. I think that briefing was part of that process and answered some of the questions, but raised some further questions.
The last point is regarding the substance use Birmingham Adults Treatment Services. We asked to provide information on the association between people living in HMOs and exempt accommodation and in treatment for drug and alcohol use by constituency wards. CGL were to provide information regarding the training that's being given to housing providers. And my understanding, and Fiona, correct me if I'm wrong here, there's a scrutiny officers have been advised that this information will be available by the end of January 2023.
Yep.
Okay. Besides that, does anybody else have any comments regarding the notes from the meeting on the 22nd of November? No? Okay, thank you very much for that. So the first section we've got is a report on the Birmingham and Lewisham Afro-Caribbean Health Inequalities Review, and we've got a progress update from Councillor Mariam Khan, Cabinet Member of Health and Social Care, and we've got Maidu Dupe, who's from Public Health, to present the report, and Monica Rosinski, Services Lead, Inequalities, Public Health. Is she present? Are you present yourself? Okay, and we've got Dr. Varney as well. Thank you all for attending today. We've got 45 minutes for this presentation, and I thought we did about 10 minutes on presentation and then the rest of the time on questions. We happy with that? Okay, so if you want to start the presentation.
Chair, and thank you to the committee for inviting me back here today. As the chair has stated, with my colleagues from Public Health, Dr. Justin Varney, Monica Rosansky and Madupe, who has just joined online, to talk to you about the important work that we're leading on in tackling health inequalities in the Black African and Black Caribbean communities. So Birmingham City Council and Lewisham Council recently undertook a review of health inequalities affecting the Black African and Black Caribbean communities in our areas. So the Black Ear Review has been endorsed by both Lewisham and Birmingham's Health and Wellbeing Boards, and the report was published in June this year. Members of the committee should all have a copy, and there is a link to the full report on the council's website. So to deliver on the recommendations which came out of the review, an implementation board was set up, which I'm the deputy chair, and it was established in October, and local engagement partners have been commissioned through an open tender process to support community engagement during the implementation phase of for African and Caribbean communities and for young men and women from the community. These are now into the contract agreement phase. The NHS ICS has established a specific working group to focus on the opportunities for action relating specifically to NHS provision, and there's a GP lead who's working to the Director of Public Health on moving this forward. So back in October as well, there was a parliamentary event that was co-hosted between MPs from Birmingham and Lewisham, and as part of the continued work to highlight the review and its recommendations, the NHS EI National Director of Inequalities has committed to using Black Ear to challenge every NHS Regional Inequalities Board to respond to the report and its findings over this year. So this is something that the work has been done between Birmingham and Lewisham, but it's being used across, regionally across different boards who are looking at inequalities through the NHS. In terms of staffing, a fixed-term dedicated team is being recruited currently to support the implementation, with an officer starting in post this month. So the Black Ear Implementation Board is actually a subgroup of the Creating a City Without Inequalities Forum, which is in itself a subcommittee of the Birmingham Health and Wellbeing Board. And the Black Ear Implementation Board will oversee the implementation of the opportunities for action which have been identified by the review, and also to co-produce the implementation plans as required. It will mobilise, influence and work collaboratively with partners and agencies. Basically, the goal of the review is very simple: to break the cycle of inequalities and disadvantage for Black African and Black Caribbean communities and reduce health inequalities that are affecting them. The first stage of the mapping of the council's and partners' actions to implement Black Ear findings has been completed. It also includes mapping across the integrated care system by the ICS Black Ear Task Force, and the mapping will inform the overarching implementation plan, which is currently in draft form and shared with you at Appendix 3, setting out the key priority areas, the activities or inputs, and the corresponding outputs or outcomes. And then it will come to the Health and Wellbeing Board for ratification. So while this is going on, at the same time, the community engagement partners have also started their activity, and they'll be working together to align their activities that will form part of the overarching implementation plan. The activity continues with the initial focus on developing a shared approach to ensuring cultural competence within services, starting from maternity and non-clinical setting to be confirmed. Improving health screening offer and take-up by Black African and Black Caribbean communities has been identified as a second most important priority that requires co-production across various system partners and the communities. ICS have also been accelerating their work within mental health and maternity services, the latter predominantly through the local maternity systems infant mortality task force. And then in Appendix 2, you've got the terms of reference for the review, which are outlining the reporting structures and the frequency of meetings along with the membership of the board, so you can see who else is involved. And then in January, we will have a forward plan for the Black Ear Implementation Board, and we're in the process of setting up a BCC task force to pick up the pace on the opportunities for action that the council needs to take a lead on. And so the focus for the last and the next board meetings is on establishing the system-wide approach to co-production with communities and the work around developing cultural competency within the services, a co-production subgroup to progress the work and develop a costed plan for delivery is being established. So I hope that that gives you a bit of a sense of the activity that's underway and the commitment of both of the councils to identifying and tackling the health inequalities that affect a large sector of our population. There's obviously a lot more detail within the report itself. And then I will just hand over to, I'll just pause for a moment because I was going to hand over to Monica, who will be able to give a bit more of an update on the ICS task force. That's okay with you?
Yes,
yeah,
that's fine.
Thank you.
Sorry about that. So ICS task force is chaired by GP Dr. Anya Comfort. It has a very broad membership from across the ICS, including all NHS trusts operating across Birmingham and the local maternity system representation. The task force meets every fortnight and the meeting started in September, and they have been also elected by community representatives recruited to be part of that group, as well as the Black Implementation Board. And the following draft plans, implementation plans, have been already presented to the task force to date. These are from the Birmingham Community Healthcare Trust, Birmingham Mental Health Trust, Birmingham Women's and Children's Hospital, and University Hospitals Birmingham. And there's the future plans will cover primary care, also the merged community partnership plan. And work has started jointly between the led by the Black Implementation Board, between the ICS as well as the council's leads and community partners on the development of cultural humility training. ICS are also undertaking currently culturally sensitive review of all screening programs to ensure that they will cater for our Black African, Black Caribbean communities in a culturally sensitive way. And there's lots of other work that started to happen. Some of those plans that have been already presented to the task force are under delivery. For example, 29 actions, opportunities for actions have been identified for the Mental Health Trust, and there is work jointly with the Black Pride Birmingham taking place in alignment with the Black Implementation to ensure that services, mental health services, are better tailored to the needs of Black African, Black Caribbean communities. That's all, thank you.
Thank you, Chair.
Okay, thank you. That presentation was really useful. Questions, members? Councillor Moore.
Thank you, Chair. First question, why Lewisham? Don't particularly have an issue with partnering with Lewisham, but I don't quite see the link with Lewisham. So I assume there is a logical explanation behind that. So but I'd be particularly curious as to why we've partnered with Lewisham on this project. And the second one is, I've been on the council 11 years now, and that this has been a conversation that's been ongoing throughout that time, looking for trying to address the inequalities, particularly health inequalities in various factors. I know there's been at least one inquiry, as well as various conversations and promises of action, which, quite frankly, would appear not to have delivered much, given that we're still having this conversation almost a decade later. So what is this actually going to achieve to make a significant improvement? Because what would like to avoid, assuming I'm lucky enough to be here in 10 years' time still, to be having this very conversation again. So what is it about this report that's going to achieve something that previous work hasn't?
Thank you, Councillor Moore, for your questions. I think I'll start off by trying to answer your second question first, and then I am going to hand over to Dr. Varney, who will be able to talk through the reason why it's Lewisham was chosen and why this work was produced in collaboration with Lewisham. So, you know, I hear you, and I agree that, you know, conversations around health inequalities have been around for a while, and actually it's almost as though it's sort of been bubbling over for a while and not really kind of come so much to the forefront that it's It's clearly like one of the cabinet members' priorities. It was the previous cabinet member's priority as well. And I think that the difference with this report is that the way in which it's been conducted from the start to the way it's been done, so it's not just focused on Birmingham, it's looked at, as you stated, the health inequalities amongst communities living outside of Birmingham as well, to identify that there is an issue around the inequalities faced by people from specific ethnic backgrounds and ethnic minority backgrounds, specifically looking at Black African and Black Caribbean communities in this sense. And so the purpose of having that kind of collaborative work was to be able to see that it's not just a Birmingham issue, that this is a wider issue, which is also the reason why this report is being used, the review is being used beyond just Birmingham and Lewisham now. And how will this be different? I think, fingers crossed, if any of us are still around in 10 years' time, we won't still be in the same position. And I think that I've got faith that the whole process from start to finish around how the review has been done, working with people, there's a lot of co-production taking place, communities are involved properly, not just in an engagement way where they fill out a survey, give some opinions, and then officers write something and put something together. It's being done in a way where, there's real engagement and co-production taking place. And I think that the implementation board factor at the stage that we're currently at is also something that's different. That hasn't necessarily been the case on any previous conversations and discussion around inequalities. And I think that it works timely also with health inequalities being sort of the subject at hand in terms of with the integrated care system. Obviously, there's lots of other things going on within the ICS as well that they're having to focus on, but it's sort of the timing works well with health inequalities being on the agenda. And I think that us coming out of the pandemic as well has played a bigger role in identifying and recognising how bad some of the health inequalities are. So I think that timing, this is probably the right time for a piece of work like this to happen, but it's also important for us to make sure that the work is carried out in the best way possible, so that we take this opportunity to ensure that, in 10 years' time, it doesn't just become a review that's pointless. And then moving forward, at the moment, we're obviously focusing on Black African and Black Caribbean communities, but we do have an idea of a view to see whether, that in the future, perhaps not at such a large scale report or a review format, that within public health, we'll be looking at other communities as well. And the starting point of that is the community health profiles that we've already launched and have gone live, not just looking at race and, those sorts of inequalities, but also different, disability, sight, hearing loss, LGBTQ, religious. So there's loads of different of the other protected characteristics which are within the different community health profiles. So the idea is that with the good go of this going ahead, and then the opportunities for action that have been identified, with benefits coming out of being able to do this review, that potentially opens up the space for something similar, maybe on a smaller scale, having to have the blueprint of what works well to see whether we can implement something similar in other communities who live in Birmingham. And so that's, I hope that sort of answers your question, but I'm going to hand over to Dr. Justin Viney, who perhaps can add to the second question, as well as looking through the reason why Birmingham and Lewisham came together to do this report.
Yeah, so let me do the history bit first. So back in 2019, we were part of the Childhood Obesity Trailblazer programme, the national initiative working on childhood obesity. Lewisham were a partner in that. The Trailblazer, all the local authority Trailblazer teams came to Birmingham. I'd been in post probably for months at that time. I was looking at Monica, she wasn't with us then. And over lunch, we'd been having discussions around actually how limited the exploration of ethnicity was, that we talked about BAME and we homogenised all ethnic communities, and how myself and my counterpart, which Catherine Mbembe in Lewisham, were really frustrated by that, and actually could we open up that conversation more. We were joined in that conversation then by the Deputy Mayor of Lewisham, who was very supportive, and then subsequently had a conversation with the cabinet member at that time, was Councillor Hamilton, to say Lewisham are up for exploring this, we're up for exploring this, we already have a relationship through the Obesity Trailblazer. It helps also then that Birmingham has the largest number of African and Caribbean people of a unitary authority in the country, and Lewisham has the largest percentage of any authority. So it also logically, even if we'd have stepped back and gone, hold on, why are we going with Lewisham? Look, we've got the most and they've got the large proportion, so it absolutely worked. What's interesting is there are some differences in that they have a much larger Caribbean population. Their African population is slightly different from us. So through the journey, it's been really helpful because in some of the discussions, they have more representation from affected communities than we do. So that's the kind of where we got to. What we've agreed to is, since the report was published, moves from being a marriage to being cousins. So in the implementation phase, Birmingham and Lewisham are implementing separately, but we're sharing learning with each other as we go through it, so that we continue to learn and evolve. Nationally, the report has been received and is being taken forward by the National NHS England Director of Inequalities, who is taking it to all of the NHS Integrated Care System Inequalities Board to go, what are you doing in response to the recommendations? In terms of what's different now, I think as Councillor Khan has set out, the review very specifically focused on what actions need to change, not describing the problem. It does describe the problem, but it actually focuses on what the opportunities for action are, and they are based on the evidence, and that's both the published evidence, but also the experience of lived experience of citizens and the involvement of providers. So we try to make the recommendations things that are fit within the realm of reality, as opposed to a kind of whiteboard wish list. Now we move into the implementation phase. We have a dedicated team, which is fixed term, to move this forward. I think the commitment from the ICS is more than I have seen in my entire NHS career. At a local level, this type of commitment is quite unique. So there is a huge amount of appetite, and many of the things that we will change through Blackyear will benefit many other communities. Although the focus and the starting point is our African and Caribbean communities, the work that is already evolving through the implementation board on cultural competency and deeper understanding of what does it really mean to be a culturally intelligent organisation, and what does cultural humility and safety look like in the delivery of services, and how do we get there, will benefit all diversity. So it's a starting point. We are working still on the dashboard of indicators. And one of the key bits that the review highlights is the complete inadequacy of the reporting of data by ethnicity by all public sector partners. So a key element of the work which Monica and the team will be doing over the spring, which we are now engaging with the Combined Authority on because they're very interested in supporting, is around a data standard for ethnicity, because what we're collecting is not routine, it's not collected, and it's not granular enough for us to understand the city's diversity. We can do better, and therefore it's clear, livable. So I hope this committee will see over the subsequent reports progress in action, but also progress in.
Okay, thank you. Councillor Tilsley.
I think the point that Justin has brought out is that Lewisham have got the largest concentration. We have the largest number. Is perfectly correct, because in a previous incarnation, I actually ran and managed a training program in Lewisham, and the statistics were pretty stark. And you could make those similarities between training programs that I ran in Birmingham and training programs in Lewisham. So yes, I would agree, and I think that there is learning to come from that. The only thing that I would say is that I'm very grateful that I don't manage them now with the transport problems that there are. Thank you.
Sheridan, I think I just note your comments, Councillor.
That's all that there is. I'm just supporting.
Councillor Pritchard.
Thank you, Chair. Yeah, I mean, it's clearly a great piece of work, and you know, it's kind of fantastic to see it getting started. My first question is: I note that the implementation board was only for this first meeting only took place in November, and yet the report was launched in June, and that's getting off 5-6 months between a launch and the beginning of implementation. Now, I'm slightly reassured by what you said in response to Councillor Moore's question that this is a what can we do report, not what the problem is report. But that's quite a lag from publish to start implementation. And I suppose my concern would be that it does end up another problem finding report, not a doing report. And when you see lags like that, we obviously got the momentum from the launch, and then nothing for 6 months. And I've seen it with other things that council, do that delay, and then things kind of fizzle out. So I suppose, why has it taken so long for that implementation board to meet and kind of get started? And will that have any adverse effect on getting the change? And the second question is, in terms of the changes that the report is outlining to make, and hopefully improvements we see, how is that going to be measured? Is that just going to be measured by the implementation board kind of looking, we've done that, tick, 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 or are we actually going to ask the people it affects about are things better for them on the ground, and is their lived experience any better?
Thank you. Thank you, Councillor Pritchard, for your questions. I think that the first question around the timing, I guess it's a good question, and it's helpful that you've asked that so that we can clarify and explain what's sort of been going on since June till October. So the first time we met was in November, but the board was officially set up in October. And there's still a bit of a lag and a gap between June and October, sorry. And the main reason for that is because the actual report went sort of live and was published in June, but the implementation board, people that were involved, that are now involved in the implementation phase, there was some time that needed to be taken in order to get that board set up, including some of the community engagement partners. So there was a tendering process that had to sort of be set out to see, to make sure that we've got enough representation from the different aspects of the communities that the review is seeking to work with. So somebody from an African background, people from a group or an organisation from a Caribbean background. And so the timing was basically just to ensure that we've got the right people involved with the board. So not just those community engagement partners, but also identifying the right people through the ICS. And there's the ICS task force that is being set up, or has been set up, and we've got the chair of that task force who's involved with the implementation board. So the timing, I guess, was just the setting up stage as opposed to the getting the work done stage. It obviously took a few months, but it was mainly just to make sure that the tendering process was done properly, and that the people that make up the board, are sort of as broad and experienced, and we ensure that everyone who we think should be involved or has an opportunity to be involved had that chance to get involved. But I will also say that we're still in the process of recruiting a chair for the board, so that's the only other vacancy that we've got at the moment. And when I bring in Dr. Justin Varney or Monica, who'd like to sort of chip in, you're going to talk through where we're at with that.
I'll just chip in on that overall response, actually, because also we were recruiting to the dedicated senior officer and project support officer roles to implement that over the summer. Incredibly difficult to twice recruitment. But I wanted to say that actually the implementation really started in March, so that we had the report, the first draft of the report, and as soon as it was published, particularly in public health, we're really galvanising the various teams to take on board the opportunities for action around healthy behaviours, health literacy. There's been an enormous amount of work actually going on also within the ICS. Around that, and we in appendix, appendix 1, which is the progress update within the papers that were shared with the committee. This is actually the work that had happened between March and October. So there's been an implementation that started in a kind of as well controlled way as we could have afforded it within the capacity we had. And then whilst we were setting, so we were quadruple tracking actually. We were setting up the board, we were recruiting to the team, we were carrying on with the engagement, dissemination of the report, promotion of the opportunities for action, and getting partners on board. Some of them, like the ICS, set up a task force as a result of it. And we were also implementing within public health in particular, but also the task force started the implementation as well, drafting plans. And so on. So there was a lot of work going on in the background. And what was the other thing?
Another question was about measuring them. So in terms of how measurable the outcomes will be, I'll bring in either Monica or Dr. Usmani, if you'd like to, but there will be a dashboard that will be set up to measure both the progress of the project and the implementation that will have had on the health and well-being of the people, both from Black African and Black Caribbean communities. So that will be an ongoing sort of live, changing, moving document dashboard that you should be able to, when we're at that stage, see how measurable the outcomes have been.
I think the other thing to add, and as a direct result of Black Year, the ICS's partnership strategy, which the draft has just been approved by the SF partnership last week, has a specific set of indicators in it relating to ethnicity. And that directly links back to what Black Year said around one of the challenges is that even when data is collected, it is not being monitored. So that includes for the first time a commitment from the NHS to publish data on uptake screening, uptake vaccination, and physical inactivity in ethnic communities broken down by ethnicity. So those are some of the indicators. There are many others I wish we did have, but as Black Year showed, we don't get, for example, life expectancy broken down by ethnicity at a local authority level. It's just not available. So there is a significant strand of the implementation which will be around building more and more granular dashboards, and that ties across the City Observatory. We're working closely with them. Just on the delay, I would also just mention that small thing called the Commonwealth Games, in which my team were playing a significant part, both behind the scenes protecting and keeping the city safe, but also in delivering the legacy projects. And Black Year fed into that in the work that we did, particularly around feeding and nutrition. So there were other things that I'm afraid the team I did have to divert them onto for quite a lot of the summer.
Can I just chip in on the dashboard as well, and the indicators? There's really 3 levels of kind of, measures that we're going to be using. One is actually a whole raft of public health outcome indicators that are already in the report. These are from the global town impact measures on the health well-being and health outcomes for those communities. That are reported usually annually, or some of them even every 2 years. And that is the one set of measures. This is the kind of long-term impact that we want to see Black Year is going to have. The second level is all of the activities and the milestones. So it's actually the progress we make against the implementation of the opportunities for action. And that won't necessarily fit within the dashboard as such. It will be more through the reporting mechanisms. But also, there's the third set of indicators, which is incredibly important. That as part of the better data theme that we'll be exploring on the Black Year implementation board, there's an opportunity for co-production with our communities of a set of indicators that would be measuring exactly what was mentioned earlier, how they feel, the difference that all of those actions have had on the communities, on the citizens in Birmingham. This group of different communities, and we'll be working with them to ensure that we can capture those perceptions.
Thank you very much. Councillor Pocock.
Yes, thanks, Chair. 3 questions, if I may. The first is to do with the way we're organising this. I was interested in the structure we've got on para 5.9, Councillor Khan mentioned this, the Birmingham Health Wellbeing Board, and then the Inequalities Forum, etc. Then we're impacting also on the ICB, Birmingham and Solihull footprint. So are we also engaging Solihull beyond the ICB into the work of that local authority? Are we becoming Birmingham, Solihull and Lewisham? How do you deal with that kind of interface is the first question. Secondly, interested in the work you're doing with community researchers, commissioning communities to get involved in researching their own beats. I think that's an interesting step. Could be interested in hearing a bit more about how you intend to go about that to really make sure we're getting good, rich, reliable information from that source. Third point, sparked by Dr. Varney's comments about moving from the rather superficial term of BAME into African and Caribbean, but that in itself prompts further thoughts about how far we generalise African and Caribbean. I know we did a big piece of work, I think, on the Somali community, very specific identity, very tightly bound culture. How far can we approach this through a generic model for African and Caribbean, or how far are we moving to a kind of kaleidoscope of different communities in the manifested way in which they're current? This is like Birmingham. This is a dilemma, isn't it, about how far you go down the compartmentalisation route, how far you generalise. I'm interested to hear how you're wrestling with that dilemma.
So if I can take these three. So in terms of working with Birmingham and Solihull, it is, I think, fair to say Solihull do not have the same ethnic diversity as Birmingham, but they recognise the value in collaborating in this work. In terms of the way the governance fits together, the implementation board is held by Birmingham. Underneath it, there are the ICS has an implementation board which reports into the overall Black Year Implementation Board, but also reports into the ICS Inequalities Board. So that's where it has a kind of dual reporting line. That's where Solihull kind of benefit from Black Year rather than them joining the kind of Black Year implementation. And Reid Tennant, the DPH in Solihull, I know is very supportive of this work, wants to learn from it, but also this is not a significant population in the context of the Solihull diaspora. And one of the interesting bits, I think, working through the ICS will be how Solihull takes some of the work that we're doing on cultural competency and apply it to their Central and Eastern European population, which is a very large and growing ethnic community for them. So that's how it kind of joins up. We have a lot of interest nationally from other authorities in the work we're doing. So one of the commitments we're making is to try and be as transparent as possible on the journey. This is a journey, it's not going to be one and done, and it's not always going to work beautifully. In terms of the community researchers, the work has been really spearheaded, as Monica alluded to. Through the whole of Black Year, we haven't waited for the final report to get going. So the work that we did at the beginning around maternity in early years very clearly set out concerns around maternity services and their support for Black women. And so working initially with West Birmingham and now across with the Birmingham Solihull maternity network system, we have developed a network of community researchers focusing initially on infant mortality. We have 2 commissioned academic providers who support the community researchers, and that is also providing support to the other community research projects in the council. So there have been kind of 2 elements. First of all, getting up and going around infant mortality and using that and the task force that the committee is well aware of to drive that forward. The second is then mapping all the other community researchers we have across the council, trying to bring them all together under a single set of academic support networks. And then the third now is building out as a model for the council. And we're working with the City Observatory and Richard Brooks on that because it is a really important part. Between Black Year, the Poverty Truth Commission and the community researchers, we really are creating different models of truly co-producing solutions. The third point around going beyond the BAME, and particularly that point around the African communities, it's the reason we have the community health profiles, which are a desktop-based profile of inequality, but they are supported by a year of co-production, co-solution creation with communities. And as part of the Commonwealth Games legacy, we produce community profiles for our Kenyan, Nigerian, and Somali community. And that was in addition to a range of others, including our disabled, our lesbian and our trans communities. Our deaf and disabled and our sight impaired disabled communities. That year of embedding is around working with a community partner who takes the data, the evidence, and sits down with the community and says, so what do you want to do with this? Part of it is about empowering communities and giving them the knowledge and understanding of the evidence base, but it's also got some to create solutions that the community feels will. What's been really powerful in those three African profiles is they really have demonstrated significant differences. In Birmingham, we have a large Nigerian community, a reasonable sized Ghanaian community, and then we have a lot of other quite small African communities and, of course, a large Somali community. We are large enough that our Nigerian community tribal politics is important to understand. That's where the community profiles is helping us. Nationally, we are the only authority that's in this space. So we're working closely with the NHS Races Centre to share our learning and our findings. Why there's quite a lot of attention on Birmingham and what we're doing, because we are at the front of, both in the UK and internationally, actually scratching the surface of these euphemistic terms like BAME and LGBT and going, our citizens deserve a little bit more understanding. What we do need to do, and I think it's important to acknowledge the committee, this is not perfect on everything, is that we do need to invest over 2023 in engaging our own staff across the council in recognising these profiles and understanding them, because that, I hope, will then play out in better equality impact assessments. So when you see papers coming through to Cabinet and to scrutiny within EIA, one of the reasons for doing this is it will really help officers properly answer the question of, does this matter? Are there particular inequalities? So it's an ongoing journey, and it is a significant journey. We accelerated during the Commonwealth Games because of the Commonwealth Games to acknowledge more Commonwealth nations. The team will be dropping back to now the aim of doing 4 of the community profiles a year. But this year we will commission 11 commissions to work with us on the community profiles, and that's in addition to the 4 commissions we have in Blanket. That's 15 different organisations working with community's identity, which is a significant investment in the council and a significant change in practice.
I'd like to note, Chair, I think that's a really significant piece of work. Well, it's nationally path-breaking type of piece of work, and we should keep a watch on how it's developing, because it sounds like a really positive.
That's right, Councillor Pocock. Before I bring Councillor Moore back in, Fiona wanted to raise a point, I think, on item 5 in terms of mental health for Black African and Black Caribbean populations.
Yeah, it was just to make the connection between the inquiry that this committee is doing jointly with the Children and Young People's Education, Children and Young People Scrutiny Committee. So just if there's any information, that inquiry just focus on the mental health of children and young people. So if there is any information that's come through the last year report, if you could feed that through, we can share it in the committee. And
thank you, Chair. Once upon a time, we had an Equalities Scrutiny Committee, which the Cabinet will be aware of, because you chaired it once. That was abolished some years ago. Does the Cabinet member think the removal of that committee has meant that there's been less oversight and less scrutiny of equalities issues since that decision was taken? And given that there's a huge piece of work coming up, and given it's important that we hold the executive, which you're now a part of, to account, that perhaps it's worth revisiting that and seeing if there's a greater focus on equality, rather than it being kind of lumped in with all the other scrutiny committees where there are competing time resource priorities, and so equalities has not been scrutinised to the same extent it once was.
Thank you, Chair. Thank you, Councillor Moore, for your question. I think that you're right that equalities overall are a major issue, whether that's health inequalities or more generally in a broader sense. And I did chair that committee once upon a time. It felt like such a long time ago when you mentioned it. I was like, oh my God, I did. But yes, I did. And I'd say that you're right that there isn't dedicated space to discuss and just focus on inequalities and equalities overall as it stands in the current structure. But I think that it can be seen in 2 ways. That, on the flip side, ensuring that inequalities and equalities are discussed within all aspects, all committees and all areas of the council's work could also be a way that, we need to ensure that it happens in an effective way. But in terms of your direct question, I guess I don't have a direct answer because I wouldn't be in a position to be able to make that happen. I'm not the leader of the council. And so I wouldn't be able to sort of reshuffle and talk about what I think that the scrutiny committees should be named or should look like. But I guess I think it's a fair point that we don't have a committee that looks at specifically issues around inequality generally. And I think that there's definitely space for conversations like that to happen. But I think that what we do have is this scrutiny committee, and we've got a piece of work that Public Health have been doing around health inequalities, and we'll just, as it stands, continue to try and feed this piece of work in all of the various different boards, and obviously feed that into the Health and Wellbeing Board, and then also work closely with our ICS colleagues in ensuring that this continues to be not just a sort of very local issue, but just that we in Birmingham can help touch on more regional and national aspects through other ICSs. But I guess, as I said, I don't have that power or decision making in my portfolio to be able to discuss or decide on how it should look. But thank you.
I thought on the point about the way that scrutiny looks at inequalities across the committees. So the Coordinating Scrutiny Committee has looked at the Everybody's Battle, Everybody's Business Action Plan, which has connections with this as well. But the other piece of work that we've been doing, it might seem like more a bureaucratic process, but it's to make sure that all reports that come to scrutiny have a proper cover report that includes an inequalities section. So I'd encourage members to look at that. And if you don't feel that the information in that answers the issues that you have, then do ask them at the meeting, because that's, it's a focus for all scrutiny committees that should have that opportunity to ask that question.
Please, thank you. I think just adding to what I've already said, that with this Black Year Implementation Board feeds into the Creating a City Without Inequalities Forum. So there is space, not necessarily in a scrutiny format, but as a subcommittee subcommittee of the Health and Wellbeing Board, which is specifically dedicated to creating a city without inequalities. So there is that element and that layer. I hear, as I said, that it's not necessarily in a scrutiny format or an overview and scrutiny committee format, but there is definitely on a board level, there is space for this sort of work to feed into, and then be sort of further feed into a board that's a statutory duty of the council. So, and then obviously we do have a cabinet member, Councillor Cotton, whose portfolio is majorly focused on, equalities overall. So, yeah, I just thought I'd make reference to that point as well. Thank you.
Yeah, thank you. I've got a question myself. I was looking at item 5 on goals, and there seems to be a large emphasis in terms of training. And I just wonder, is this effectively a reboot process where you'll be actually restarting training again? And are you looking to have a program of training for Birmingham and Lewisham, which would you be having totally different ones? And how have you sort of constructing that? Have you brought a particular agency in to advise on that?
So when Blackyer talks about training, I think first of all it's important to say that the evidence that we heard through the 18 months of sitting was pretty overwhelming, that the 1 hour of e-learning approach to quality training is not sufficient and does not provide cultural competency practice. Blackyer makes recommendations around developing and co-developing cultural competency. And the first stage of the implementation has been to define that. So we've had a session. The first session with the implementation board was getting everyone to collaborate on what do we mean by cultural competency, and that led to this language of cultural intelligence, which is about how we, in our strategic response to the diversity of our communities, are culturally intelligent, and that will require a training and support and toolkit approach. And then how we deliver services fits with cultural humility and safety. So it's not one training package ticks the box and everyone is solved. What I envisage the implementation board developing is a set of training standards, which is then up to individual organisations in the partnership to implement. And of course, we'll be working with the council to be upfront. Getting that moving first. But the aim of Blackyear is not to create sticking plasters. It is to fundamentally change the way we do business. And that's why in the training space, we won't be saying Blackyear's commissioned this provider. Blackyear will produce a set of commissioning specifications. Then it will be up to scrutiny and the cabinet member to challenge the organisation to go, and have you actually used them? And to challenge me and the team of, have you made sure people are using them? So that's the model I think we're working towards. We have done quite a lot of groundwork over the last couple of months, actually exploring what international models of training are in this space, where people are able to show evidence. That's led us to the 3 terms of intelligence, humility, and safety. And that forms the basis on which we can provide those training specifications.
Would I be correct in assuming you'd be moving away from the e-learning model? Because I think sometimes there's a temptation on the e-learning system to go straight to the questions, which means you effectively don't do the training in a real sense of the word.
I think the evidence base of what we've looked at so far around this type of training is that, I'll dodge it a bit by saying mixed methods training, in that it's not an either or, it's actually what you need is a program of training in which cultural competency is embedded across every bit of training you do. And then you have specific training, which is labelled cultural competence training. And that's a combination of knowledge training, which might well be e-learning. An e-learning version of the community health profiles, for example, would be perfectly appropriate. But supporting someone on how do you engage with someone and create a culturally safe environment in your clinical practice or in your provision of housing service, for example, needs to be face-to-face. It needs to have a bit of role play. That kind of behaviour change and attitudinalship training, the evidence would suggest is not effectively delivered through e-learning. So I think what we will be getting to is a series of training standards which require organisations to have a mixed methods approach to training and not say one hour e-learning.
Thank you for that. We've got time for one more question if anybody wants to take that opportunity up. Okay, thank you very much for the questions and thank you very much for the presentation. Okay, thank you.
Okay, if I leave now, is that, please?
Yeah, of course you can go.
You don't think this.
Okay, committee, we're coming on to item 6, which is the Birmingham Safeguarding Adults Board Annual Report for 2021-22. And we've got Dr. Caroline Cuss, Independent Chair of Birmingham Adult Safeguarding Board, and Asif Mansour, the Business Manager, or BSA. We're going to present the report. I just want to sort of say before we crack on that a previous meeting in November, the committee received a report on the provision of substance misuse services and looked at the correlation between data previously received on the density of exempt accommodation and maps that showed the areas with the highest number of clients accessing substance misuse services. And it was recognised that some of these would be vulnerable individuals, and there was some concern that some of these could be exploited, where, example, people are approaching people on the street for money, and potentially, as we often see ourselves at major traffic junctions. And we wanted to know, what does Safeguarding Board have any policies and procedures regarding the exploitation of adults in this way? And has any learning been identified which has resulted in improved practice on that matter? So that's something to think about, as well as the presentation you again look to do. And I think we've got 40 minutes for this. So if you want to do about 10 minutes on presentation, which will give us half an hour for questions.
Well, thank you very much, everybody. It's really good to be here. I'm Carolyn Cuss. I am your independent chair for Safeguarding Adults for Birmingham. I joined you in October. So I've been with you for the last 3 months, took over from Cherry Dale, I believe, who you may have met last year, presented to you last year. So I've got Ash with me, who's great, because anything I can't answer, I'm going to default to Ash. You've got, I'm assuming that you've had an opportunity to go through the report anyway. So I'm going to just do the salient points, I think. So I'll quickly go through in terms of kind of page numbers and what I'm going to pick through. So if we start on page 4, the infographics, and that I just want to highlight in that one a few things there. You can see from there that we've had over 11,000 concerns raised this last year, of which 843 of those concerns became inquiries. So that means that obviously there's a triaging, go through a triaging before they actually go through if it follows through. So of that 843 went through. I think it's good to point out that of that, 90% of people felt their inquiry had achieved what they wanted. So part of our work with partners is making sure that people are at the centre of all of this and that they get, their wishes and views are heard. So 90% good rate that people, got what they wanted to achieve. If the other bit I wanted to just raise with this, because we're seeing a little bit more of it and we're expecting more coming through, is that we are seeing a very large increase in inquiries and concerns raised around abuse and of self-neglect and neglect. And a lot of that is happening in people's own homes. So there's work around neglect, and we have policies on neglect that we agreed. I think it's last year the policy was agreed
in November.
So we're encouraging people to use that policy because it's a good way of following through. But we are seeing a significant rise in self-neglect and neglect in people's own homes and in care homes and nursing homes. So it's been something that we're going to need to follow through as we track that through. I wanted to remind you on page 5 what the vision is about people with care and support needs in Birmingham and how we want to keep them free from abuse and harm. And that is, that's our purpose. That's why we're here. That's our vision. And the purpose of this report was actually to reiterate that and to look at the assurance that we've done over this last year. I want to take you to page 9, which highlights the strategic priorities for 21-22. As you'll see, I want to remind you there were four priorities set around communication, prevention, making safeguarding personal and learning and development. I think the key thing in there is that all the way through those priorities is the person is at the centre. So it's the person is at the centre through this. So we've been really clear about making sure that people are involved. It's important they are as we go through any safeguarding event. I want to take you to page 10 and 11, and that shows what the board's achieved in 21 and 22. So against those priorities, you'll see that there were a number of achievements. We said what we'd do. So if we looked at making safeguarding personal, for example, we asked that the assurance that people will be supported. We've held briefing sessions. We've met with practitioner forums. We've talked a lot about self-neglect. We've talked about the Mental Capacity Act with people. We've looked at domestic abuse, hoarding. So a lot of work has been done over this last year against those priorities. We continue to share the learning and development because that's an important aspect of the board, is that we do need to learn from what happens. So we do a lot of sharing and learning with our partners. We've got, as I said, we've got the new multi-agency self-neglect guidance, which was launched last year. We've also been developing the safeguarding dashboard. So that's our performance data that gives us the intelligence to see what's happening and where. And it's a very detailed dashboard, but it's still a kind of work in progress. So we're still working on that to actually pull out further details as we go. You always find something else that you need to know and follow through. Very clear that dashboard needs to tell a story. It needs to be able to tell us what's happening, why it's happening, and gives us a focus. pages. Let me take you to 17. So page 17 talks about making safeguarding personal, and that's really important from an adult safeguarding perspective. The Care Act is really clear, is that about when we working with people, that we actually take their views and wishes into account. So there's been a lot of training with staff around making safeguarding personal, about making sure that people's views and wishes are heard. So somebody that's at the centre is actually we're listening to them and making sure they've got we make sure they've got the capacity as well. And where there isn't capacity, that they're given advocates and support to enable us to fulfil those wishes and needs. I'm going to take you to page 18 and 19. In here reflects citizens' stories. So it's really important that we hear the voice of the person. And therefore, each of our board meetings starts with a story, a citizen's story, and we talk through that. And importantly, tells us what we've learned from that, and the learning that we can take out into the partnership. So that is a really key element. Pages 20 and 21 talks about safeguarding adult reviews, and just point out to you that we've completed 3 reviews from the previous year, and they were published reports. And those findings and were shared then with partners and put into learning, so that partners could take away and learn from those. This year, there's been 6 safeguarding adult review referrals. They didn't meet the criteria for review, but there was quite a lot of learning for those. So that's been taken forward into our learning and development subgroup to look at how we can learn from those. And finally, let me just talk a little bit about the assurance report. So the biggest part of the board is actually seeking assurance. That's the board's role and function, really, is to seek assurance from our partners that they're doing what they should be doing. And we do that through annual statements. So we receive statements from our partners. We also, the citizen's voice, as you can see, is very important. But also keenly for us is the data and intelligence. So we're looking across various elements, and we're working very closely with all of our partners to get that assurance and to make sure that we're actually seeing what people are, what's happening is the right thing that's happening. It's in respect to safeguarding. Page 22 just looks at some of the assurances that we saw from the CQC inspection on acute hospitals, learning disabilities, autism strategy, the Winterbourne, and recently with the follow-on from the recent panorama on the mental health establishment in Manchester, and we're looking at that in terms of learning from that. And I guess the biggest learning from that, again, and we keep talking about this at the board, is kind of so why does it keep happening? Why does this keep coming up again and again? So we keep having these. Winterbourne was over 10 years ago, and yet we've got another incident occurring again. So part of that learning from a board perspective is, well, why does that keep happening? Is there something around values, behaviours, cultures, including attention, youth? So it's learning that we take out, and then it goes back into the partner organisations, and we ask them to lead on that. And I'm going to stop there and let you. So a bit of a whistle stop. It's, as I said, I picked this up from Terry, so it's a whistle stop through, but I'm sure we can answer any questions that you ask.
Okay, thank you. Members' questions. Councillor Jones.
Yeah, obviously, I'm not surprised to see that most of the abuse takes place in the home. Do you think that truly reflects really what's going on? Because it's probably, I assume it's obviously somebody, obviously it's a relative who's done the abuse. What support do you give? Because at the moment, obviously, with all the cost of living crisis, the stresses and strains of being a carer anyway, those of us who've done it, it can be quite a stressful thing. What sort of support do you offer? And how many incidences are there where the abuse is so bad that the carer, you have to separate the carer, perhaps put the abused person in care? Or
we've got carers. There's a carer strategy, I believe, isn't there?
Right, so when it comes to kind of like dealing with actual safeguarding concern, the safeguarding board is not an operational such, so all safeguarding concerns are actually held by the local authority. So it's the local authority that would provide support. So the question that you asked around, the separation, we can't answer that.
Yeah, okay.
it's like social care that deal with those instances. And I suppose in a sense, some of the things that, we're aware of are things like carers assessments being appropriately carried out. Something that we did was there was a national document that ADAS and the Local Government Association were working on last year, which was around safeguarding for carers. We had a safeguarding adults review, which focused around domestic abuse, and there was learning from that case around domestic abuse, which is in the person's own home. And we held practitioners forums where we were raising awareness around professional curiosity, carers assessment, support for carers, and we asked for that to a case study as well as the key questions to be part of that national document, which is included. And following the publication of that, we circulated that widely to again raise the awareness of, because sometimes it can be it's not meant, the abuse isn't necessarily meant, it's circumstances that can potentially lead to the abuse. So again, it's practitioners and people being aware of what support is needed. And when we were developing our strategy, we involved carers groups in the development of our strategy, and there is a certain element on one of our priorities, our areas of work was around raising the awareness around carers, and so we've done quite a bit, and we, like I said, with the practitioners forum, and we're currently looking to see further assurance around what is happening around carers support and care assistance.
Okay, thank you, Councillor Moore. Thank you, Chair. Just wanted to go back to the little the dashboard you've got in your report. So, because it says here there were 11,861 concerns raised, and then 843 of those became inquiries. So, what happened to the other 11,000 or so concerns? So, and what would be a concern that would be recorded but not then be passed to an inquiry? Is it that these were not safeguarding concerns that therefore didn't merit being investigated, or just someone just saying it for the sake of it? Because sadly there are some people who do raise that. Or is it that there was something that was concerned, but then why was it not then investigated? I just wonder if you expand a bit on that a bit more, because it just seems quite a stark figure of the number of concerns raised, but then very few of them were then passed on. And then in terms of the service providers, presumably the safeguarding board would act on any concerns around a particular provider. Say if there was a number of complaints about one specific provider, what action would be taken in relation to that to ensure that was being addressed? Because I assume sadly there are some providers out there who don't have good staff recruitment, for example, and may have people who are not caring for particularly the elderly, for example. Now I appreciate not expecting the name and shame of any dodgy providers out there that we should be wary of, but I presume the board would act on any such concerns.
So, in regards to your first question around safeguarding concerns and the numbers that are going into inquiries, that can vary nationally. You can have some local authorities that have 99% of safeguarding concern correlating to inquiries, and there's been national work around trying to establish why is there such a difference. I mean, I came from Yorkshire, and Yorkshire number we did workshop to try and understand and compare. But what we did find, and again, what we know from the assurance that we've saw in Birmingham, is that every safeguarding concern that's reported through to the local authority is looked at. And again, safeguarding concerns again are not dealt with by the Safeguarding Adults Board, it's the local authority's responsibility. And again, going back to the board's role is around seeking assurance. So, we've been asking the questions around, okay, so you've got 12,000, safeguarding concern, so many are correlating to inquiries. Currently, we are doing a piece of work which is kind of like further looking into why is that difference, but we are assured that every single safeguarding concern that comes through the door to adult social care is looked at, the risk is looked at. It doesn't necessarily always go down to a full multi-agency process, because the figures that you've got there are the cases where it's needed a full safeguarding process. So with some of the cases it might mean that is closed off early, so that would Birmingham translated as an inquiry, but there's been a lot of work that's taking place from a lot of social care perspective, from a partnership perspective.
in order to do that.
We have a big role as a board, like you, to ask that curious question. So we will ask questions. So recently we did an audit, carried out an audit to understand who was being safeguarding, was it an appropriate safeguarding referral or not? Because often you'll get referrals coming through, say, from the ambulance service, and it's probably not a safeguarding, but there might be an issue that that person needs some care and support needs. So that's what you're trying to filter out. So that's why you'll see this, and then it filters down. But we, from a board perspective, our role is to ask those, to be curious and ask those questions. So we will delve into, and that's why the data is our dashboard's really key for us, because we go through it in some detail about, well, what does this mean? Why is this? And we do ask our colleagues in adult social care those searching questions, because that's what we're looking for. We also ask our partners, and we recently got that audit back, and we're now just pulling that, unpicking that a little bit more, to be honest.
And also we have a quality and performance subgroup as well, which is made up of multi-agency partners, whereby we get all the data, which includes the number of safeguarding concerns and the outcomes, and we're analysing and interrogating that and asking for further kind of information where we need to. In regards to your other question, which is around the care homes, again, the safeguarding hotspot are not an operational group, so any concerns about care homes again would go to the local authority, and the local authority would then make the necessary steps in order to deal with the situation. So they'll potentially involve commissioning who may lead on some of those areas, and again they'll apply a partnership approach. And if there is anything, I suppose, major, then potentially escalate to.
We could ask the board, I could ask the chair for the head of commissioning, which we'll do. And we ask them to come and talk to us about what's happening. So we're seeing, for example, in some of the tactical community, the kinds of neglect within the care home sector. So the next question is with the head of commissioning and the board as well, witness show us what's happening out there, what checks are taking place. Now we know there's checks taking place, but people ask them again with an assurance report that those checks have been taking place and people are safe. And is it that those may need some more training? I don't know, but we will find that out. But some of it that's how we're picking that up. So our dashboard, our intelligence is really key for us in order to take those actions.
And just to add to that, so in March, for example, we've got commissioning coming to the board. We've got CQC as well coming to the board. So the question that's posed to CQC is they publish a national report called the State of the Market. So we're asking them about nationally, but then we're asking them locally, what is the picture? So, how many services are inadequate, what support CQC are providing, and what partnership work is taking place. But then from a local level, we're asking what are you doing? What's the state of the local area? What support? What are the themes and trends that are?
Can I just add something to that? My previous managing safeguarding partnership in Telford, I'm just looking at the figures here because the board there would have data as well. And what strikes me is the board, the information that used to go to Telford had contacts, then concerns, then inquiries, and then reviews. So there was actually a lot of the initial contacts that would come through wouldn't meet the safeguarding criteria, but it was more about information or asking about for support or advice. So the reason I'm just mentioning it is that I think it is difficult to compare different areas because it's recorded in different ways in different areas. But I think one of the fundamental principles is that actually having those initial contacts is good. 11,000 seems like a very high number, but actually the fact that people are coming forward and raising concerns or issues or information that they want is a good thing, but then it's making sure that those are going down the appropriate route. So I'm sorry, I'm partly answering some of the question, but just from a different perspective. But I've seen similar data and it is quite complicated, but difficult to compare.
We expect it to rise because during the pandemic, we saw a reduction in referrals. So now it's going to rise, and it will get. So there is an expectation it will rise.
Madam Chair, I mean, my initial concern, obviously I appreciate your verbal update, but when I read the report previously, my initial thought was there are almost 12,000 concerns raised, and we've only investigated 1,000 of them, which sounded rather worrying. And it's reassuring to hear that something did happen with all of those other concerns, and it wasn't a case of they were just stuck in a box somewhere and forgotten about. But that was my initial reading of the report, was that we only bothered to investigate just under. I appreciate the verbal update to clarify that, and it may be worth, given what Fiona said, separating out those who are just making an inquiry. What do I do if I've got a safeguarding concern or something like that? Because obviously that is different to someone saying, I believe this person is subject to abuse, and that actually may make that figure slightly lower.
Well, I mean, and as I said, we are doing some work with our quality board anyway around the dashboard, so that's really helpful feedback, because we're looking to how we can make it. It needs to tell a story. I keep saying this, it needs to be able to tell your story, and you need to be able to understand it. So that's helpful to our conversation.
Thank you. I was looking on page 15, where you got partners' achievements on the West Midlands Police section. It indicates that CAS referrals have seen an increase of 25% in the year. And I just wondered, in terms of how much do you see the pandemic has been a reason for that? And you mentioned at the beginning of the presentation about an increase in self-neglect. I wonder how much do you feel the pandemic's had an impact on people who may be living at home and by themselves, and have either got professional or family members calling in when those visits have been reduced as a result of the pandemic?
It probably will have had an impact. Pandemic, we will sit with that. Its impact on people's mental health, mental well-being. We know from our safety. Some of the issue with the self-neglect as well is, and the next sort of, and we said this is coming, the next bit that we're going to have to be mindful is the cost of living. So people are experiencing obviously difficulty during with the cost of living crisis, and therefore that's another area that can impact on kind of neglect and self-neglect, whether people choose not to eat or heat, or as they say, and various other things. So I think the pandemic's had an impact, and I think now the cost of living will have an impact.
Thank you for that. Councillor Pocock.
Yes, just following up on the issue of self-neglect. Well, can I say, first of all, these reports are good. I like these reports. They're well presented, well communicated. You've always produced an interesting and product. All the reports we get are as good as this. Self-neglect as an issue is out there, and often it goes along with reclusive behaviour. I'm thinking here in your guidance, two things actually, the guidance and what you will do. Let's take an example in ward, a property clearly occupied by somebody who is not looking after themselves. Fire service do a safe and well check, nobody answers the door. Police call, nobody answers the door, nothing happens. If that was referred to you as a concern, how would you ensure something did happen? Because the referral system back to the ones who knock the door and don't get an answer leaves nothing to happen. And then we all hear these stories about somebody passed away. We don't even find out for months. This happens in those contexts. So how would you propose that issues like that should be addressed?
So again, just going back to what I said earlier on, the Safeguarding Adults Board don't deal with individual cases. Those are dealt with by the local authority. So again, there's a policy and procedure around safeguarding, which basically, they work in partnership with professional everyone. Try and make the contact. So again, that question potentially the local authority question, but from a safeguarding perspective, if my understanding and viewing, like if somebody reports something like that to the local authority, will be making every effort in order to make that contact, make contact networks, and again, contact with the partnership, the police, the fire service to try and get make contact with that individual. Now, when it comes to situations of self-neglect, ultimately the guidance that we developed, not every self-neglect situation will be a safeguarding concern. So the Care Act doesn't say that. But what we do say in our guidance is if you're an organisation or a worker that's come across somebody that potentially there's issues with myself and that we built a risk assessment tool within accounts the worker on. The key area to look at the level of risk, and even to hold multi-agency meeting, it's not just necessarily the local authority that would hold the multi-agency meeting, anyone can hold multi-agency meeting. So again, the guidance is kind of like saying to people, work together, work in partnership in order to kind of like support that individual.
My question though, Chair, was what happens if the agencies don't do what they should do and a tragedy occurs? To what extent does your board hold to account the failure of organisations to do what they should do in your guidance?
Okay, So if somebody with care and support needs died and it met the criteria for a safeguarding adults review, then obviously that referral will come to the safeguarding adults board, and we would then make a decision based on the information we've got whether to carry out the safeguarding adults review. Now, the safeguarding adults review isn't about blame, it's about learning. So we've been looking at getting the key partners together, getting somebody independent to act as the lead reviewer, so asking agencies around what they felt was their learning, as well as kind of like the learning from a system perspective. Then what we would do is we would make a decision on whether to publish a report depending on confidentiality and risk, etc. But as a board, one of the things that we've been doing is following on from a report. We don't just go, here's a report and here's the recommendations within that report. We've registered those organisations who are involved. We've given them the recommendations and we've asked them, can you produce an action plan on the basis of these recommendations are? Some boards just stop there. One of the things that we've been doing, our safeguarding adults review group has been asking partners to come present their action plans to provide us with the evidence about what change and what impact that has made in order to kind of prevent that kind of situation. And again, we do learning events, practitioners for any way we can share the information and tell them in briefing until we try and raise the awareness and we check it.
Partners around the world needs to take that information and learning from their organisations. So in March we had a board development session where I will be working with you and understand what's your responsibility and what's your role and take that back. We do just share things with the fire brigade at the last board meeting, saying they're putting information out because they're aware that some people are using candles to heat, and obviously that's a fire risk. So there's information going out now and advice across the partnership that will go out, that's going out publicly to help people and support people in that respect. So we're trying to do the proactive prevention stuff as well as the stuff afterwards, but it's all about in that concept of learning and development. So we learn from it. Kind of like, and I said, if it can be, we need to get to a point where if it's a never event, so it should never happen. And if it did happen, why did it happen? And we need to unpack that, and we share that learning across the board.
Okay, thank you. Any other questions for anybody? Okay. Before you go, well, thank you for your presentation. On the question I asked about the increase in CAS referrals, I don't think you quite answered that. If you could sort of get some clarification in terms of what it says, CAS referrals have seen the 25% increase this year. Can you answer that one? Yeah.
Right. So when we ask partners to give us their partner achievement statements, the police wrote this statement as a statement both covering adults as well as children, and CAS referrals don't fall under the remit of the Safeguarding Adults Board, but because they wrote that as their statement, that's why it's a little statement.
Okay, thank you. Any other question, members?
The first point that you made about the issue that was discussed at the previous committee meeting around exempt accommodation and substance misuse. I just wanted to flag that, and I don't know if that's something that the board would want to take away and think about, or if you've got any data or information about that.
So again, I suppose in the sense, exempt accommodation, and the various issues that come with exempt accommodation. The board are not the leaders around exempt accommodation. However, some of you will know that probably about 4 years ago, even before I started working in Birmingham, Cherry and the board raised the issue around exempt accommodation, the issues around support, and the following issues. We commissioned following that, which then was published, and we basically agitated and pushed to organisations to take action, which still obviously one. We continue to see evidence around what is happening around exempt accommodations for people. At the last board meeting in October, we saw assurance locally in PNI the strategy around which potentially I think I've presented here as well, which we asked for what's the elements around there. We link in with Community Service Partnership, and I suppose in because of the question of the exploitation, the issues around the traffic light, Community Service Partnership on and the partnership board as well. That basically we're looking at those issues, and we make sure that they're part of those conversations, because not everybody in exempt accommodation will, yes, but the one won't necessarily be cared for, and that's where it's kind of like wider partnership, children partnership, community sector partnership, we've got all those partnerships needed are connected up on.
Just add to that, Chair. I want to acknowledge the work you've done here. I chaired this committee at the time when Cherry Dale came to this committee and alerted the council to the potential issues around exempt accommodation and vulnerability. I think it was probably 2018. Subsequently, the coordinating ONS took this up, and then we've had all the work that's been done since then, and it's opened up that issue and it's made it a national debate. And I think you triggered it, Cherry triggered it, by raising that concern at this committee. So I acknowledge what you've done there, and also good luck to keep on the pressure, let's put it that way, because this is not going away. So you have a continuing role, but I think we should acknowledge thanks to you for having drawn it to our attention.
The whole committee would agree with what Councillor Pocock said there, so thank you for the work you've done on that.
Yeah, well, thank you to my colleague here and Sherry, who was the previous chair, which gives me a lot to build on, really, and it's quite exciting. I'm looking forward to going forward. But yeah, thank you for that, and I will make sure we feed that back to the group. So thanks very much. Thank you.
The final item we've got is the Adult Social Care Quarterly Performance Review, which will be presented by Maria Gavin. Because we've allowed more time for the first two elements of today's agenda, we're going to go straight to questions for this one without a presentation. And Maria's happy that we go straight for members. If you've got questions, Councillor Pocock.
It's on our scorecard, Chair, and Maria will be familiar with this. The scorecard measure 2, proportion of clients reviewed, assessed, and reassessed within 12 months. Continuing on red, looking at the little graph, it's actually slipped away over the last 12 to 18 months. I think there is a little uptick in the very last month, but clearly it's an issue of concern. We're running at 63%, is it? Target is 80. It's quite a big gap. So there's comments obviously in your report, but could you amplify what we're doing to get back towards 80?
Yes, certainly. As you say, you've got 2 quarters reports summarised in this scrutiny papers, and the second one shows that the proportion of people being reviewed is improving. That's a trend we are continuing to see. Board members might recall Adult Social Care had a huge recruitment campaign over the summer and the autumn to try and attract social workers. We had a very large number of vacancies, and one of the activities that was deprioritised when we were short on workforce was reviews. It was done in a stratified way. So people who have, for example, direct care payments or more complex care packages, those people continue to be reviewed. But the statutory review, say, for example, of our older adults in good care homes, those would be given lower priority because those clients would be seen in a place of safety on the whole and at less risk. So we are starting to see that improve. I believe we've recruited 62 new social workers so far, and that really will help improve our capacity. Also conscious we're going into a really difficult winter. And again, if we need to redirect community staff from community or activity or from reviews, then that is something, again, we prioritise, is the maintaining flow through the hospital and helping prevent admissions. So review is kind of quite a good indicator of the amount of pressure the directorate is under, because it is the one area where we can't fulfil all our requirements if we're under enormous pressure and have to redirect staff to meet demand, or because we're carrying high numbers of vacancies.
Councillor Jones and Councillor Tilsley.
Yeah, I'll just emphasise what you said, because I used to be working adult social, well, I did child protection, but I worked in adult social care. And I'll be honest with you, even going back to the 90s, you know, reviews are the last things that get done, let's be honest. As you said, if you get somebody into a place of safety, fine. And then if it's in the home, you know, and it's a bit of a, you know, you as a social worker, they're right at the forefront of your mind. So you're going in regular reviewing anyway. So, you know, you're keeping up to date. So, yeah, I just amplify what you've said, really. It indicates the stress that people are under. I'm glad to hear you've recruited so many social workers. That's good, because that's always been a problem, lack of staff.
Yes.
And that is the least priority, to be honest, reviewing. We all understand that you need to do it. I mean, the only reviews that tended to get done were the ones where, you know, the 6-week review, when you've gone into care and you're making sure, and then you establish it, make it a permanent placement. So, I think, you know, obviously great that we're going to have to start doing that, but I don't think we should sort of look at that as a major crisis, to be honest, in my own personal opinion.
Councillor Tilsley.
Yeah, it's leading on from Councillor Jones's comments in part, and that is lack of staff within the care home and the sector. I'm involved in a charity that provides care home places, and I know that we lost a lot of staff due to the COVID non-inoculation issue, which was then rescinded. But it's too late to turn the clock back, unfortunately. And one of the problems that we've got within the healthcare system now is that there's not enough placements available. People leaving acute who are perfectly able to leave acute beds to community beds or care beds. And this really is one of the major concerns, because we're throwing bricks at the ambulance service, and it ain't their fault, just because they can't get them through the system. So I wondered whether you'd like to make any comments. And I suppose in part what I've said is quite explosive, and it's intended to be, I suppose, because we've got to face the problem that we've got head on, because there are now so many pressures on the whole system, and we're only at the start of the flu potential epidemic. And old fogies like me will continue to fall down and break hips and legs and God knows. And the current instructions are that if you've got a broken leg, you know, forgive me saying tough titty, you'll have to lie on the floor, because nobody's going to come and scoop you up. Now, I am concerned about the whole of the health provision we've got. But one of the problems, one of the pinch points, is the lack of staff that we've got in care beds. So it's over to you.
Yeah.
Yeah. Hand grenade onto the floor.
I mean, you're quite right. The care market itself, and you'll know in Birmingham, we work with 600 to 800 care providers in the city who are independent or third sector providers. And Birmingham, as nationally, has the issue with high turnover in the frontline, low paid care workforce. As a council, we try to pay more. Our workforce turnover is better than the national average. We have lower turnover in the care home and home care and independent sector than other areas, but it's still really high. It's still about 25%. You know, we are, the care sector itself isn't funded to pay people a good wage. And, you know, you listen on the news today and, you know, care workers and healthcare workers talking about moving to other employment like Amazon. There's a big Amazon warehouse, I believe, due to open.
Well, there's a big one out at Tyseley.
Yeah,
there's another one out at Weatherhead.
And you're quite right, Councillor Tilsey. As a council, we do pay more than minimum wage to the sector, so they can pay the workforce more than minimum wage. But some of the other areas of the market are increasing their pay and offer, and it is very difficult for the health and care sector to compete. We continue to work with the care home sector. As you've heard, we focus resources particularly to ensure we help stop admissions or facilitate discharge. And in Birmingham, we've managed in social care to keep pace with the level of discharge. But that doesn't take away from the fact that the care sector as a whole is under considerable pressure, being an area, you know, which isn't as well paid as competing sectors. But we have some really good workforce. We continue through the West Midlands approaches to really try and support the care workforce and our care providers to recruit and retain. There was a big recruitment and retention payment last year that came down from national government that helped care homes and care agencies offer more funding. And we're always pushing for opportunities to stabilise the care market through, you know, those calls to national government or to the council itself, really.
But there's nothing unfortunately free in the market, particularly for care. So it either falls, because of the cut-off point, it either falls on the public purse with less than 25,000, or it's self-payers.
Yeah.
So if we push the price up,
yeah,
if the care homes push the price up to pay a realistic wage for the care assistants, it's increasing the charges to the families, which becomes an impossible burden for many of them, because they've then got to go through the whole process of selling the family home to raise the capital, and is that going to be enough? It is just a mess, and governments for the last 20 years have been kicking this can down the road. And we had the proposals 12 months ago that
It was a done deal, wasn't
it would be looked after. That can, funnily enough, has been booted down the road again, a few more years. So we're not tackling the problem. And unfortunately, there are many families that are marginal as far as their ability to pay is concerned, who are having to make do and mend. And at the end of the day, it's the elderly parents, it's the elderly person that is paying for all this. We are in an impossible situation. We had a conversation last month, I think it was, with Jonathan Brotherton at UHB. And that precise day, there were, to use NHS jargon, 140 inappropriately occupied beds. Now, in round figures, that's 40 for every of their hospitals. So that's 40 ambulances lining up outside every hospital, from Good Hope to UHB to Heartland to Solihull, who can't discharge their patients into the EU. It's an impossible situation. And we just keep on going around in ever decreasing circles, as far as I'm concerned. So it's a statement.
Yep, no, absolutely.
Absolutely.
Yeah.
Thank you for that, Councillor Tills. I think a lot of us actually agree with the sentiments of that comment. Councillor Moore?
Thank you, Chair. I wouldn't really consider 1.6 an improvement on the review of the 12 review assessment or reassessment in 12 months. I think that's very much clutching at straws to say 1.6% improvement, we're going in the right direction. I don't think that's good enough. Particularly given when you look at the charts, it's been dropping since October 2021. So it's been happening for over a year. It's great that we've done this recruitment drive. We've got 60 or so, I think it was, new social workers. But why did we wait for it to get so low before we did anything, given that this is clearly a trend that started over a year ago? I'm just rather concerned, and I appreciate perhaps in the grand scheme of things, reviews and reassessments, maybe the last thing they need to do. But they're really important still, because we've got to make sure these people are getting the appropriate care that they need, and they shouldn't just be left with an inadequate care package because people are really, really busy. So that's my main concern. But also my other question is, we've got the adult social care precept. What's that money actually going on? Because it can only be going on adult social care. So I'm rather confused as to why, I appreciate there's a lot of pressure on adult social care, as Councillor Tilsley's touched on, so don't dispute that. Ring-fence pot of money specifically for adult social care, and yet this has still been going down whilst we've had that extra money. So where's it actually gone? Because it can only go on adult social care.
I think you probably need finance to confirm how all the grants that come into the council are deployed. If I
Presumably it goes to your team because...
No, not necessarily. A lot of funding is non-ring fenced.
But adult social care precept is ring fenced specifically for adult social care.
It might be helpful to have finance to give us further detail, and I'm more than happy to do that, Councillor Moore. I think as an example, and please don't quote these figures, I think the precept brings in between 4 and 8 million. Our award to the care sector this year will need to be at least 22 million. That would be below inflation. We'd need 28 million to come up to a reasonable level. So the precept at 4 to 8 million helps, but it doesn't. It doesn't help us recruit more workers, or it just helps underpin current delivery. It doesn't help us, sort of make further improvements beyond those. And we do, as Councillor Jones said, we know reviews haven't been where we want them to be, and they continue not to be where we want them to be, until we can assure the priority most vulnerable users and the hospital and care system that we will always prioritise those areas of work. Workers themselves would love to be able to cover all the work, and it is a source of stress for care staff when you can't do that. But you have to prioritise your resource to the most immediate need. So it isn't a position we're comfortable with, but it is a position we believe is the right thing to do.
If I may, Chair, I'm slightly concerned that you're not entirely sure how much the precept is raising, because 4 to 8 million is,
I haven't got the budget.
So I would like to know how much we're raising from the precept and what that money's actually being spent on.
But we actually consider putting that question to the Resources Committee to get some further clarification.
I want to know the information, Chair.
Well, I'm sure we would get that. I'm just wondering whether Resources would be the better committee to actually get that question answered. I'm not saying we shouldn't answer that question.
But it's for adult social care. I don't see why we should be passing it off to another committee when it's, we have a report here on adult social care. We've raised funding specifically for that. I don't see what's unreasonable to ask for the detail of what that money's been spent on and why we have to pass it to another committee.
A suggestion to take us forward. This committee does receive a draft of the budget in the budget cycle, we consult on the budget. I suspect at that point, the questions Councillor Moore has raised will be transparently displayed in the budget for the forthcoming financial
Well,
year.
Chair, it won't, because that'll be for the future year. I just know it's being here.
Can we just allow Councillor Pocock to finish?
So my suggestion would be that as a matter of routine, we receive that report and then Councillor Moore can ask for any information that isn't in it to be added to it. And then he gets an answer to his question. If we get...
Well, no, sorry, Chair, I'm not accepting that. The amount of actions we've had at meetings before, I asked for one action and I'm being told, no, it has to go to a different committee.
Making a suggestion that it comes back.
No, I appreciate you making a suggestion. I'm saying that's not what I've asked for. I'd like to know what the money we raised last year, not the coming year, how much was raised and what it was
I
spent.
think at the moment, members, we're trying to come up with suggestions so we can get a proper answer to that question. Fiona wanted to make a comment.
Yeah, so just on the budget scrutiny process for this year, it will be the Resources Committee that will consider the budget proposals. And I'd made the suggestion to the chair about taking that question to the Resources Committee because it will be looking at the round. But if there's information that this committee wants, this committee can.
I'm sorry, but it's a reasonable request. I've asked for it to come to this committee. I don't sit on policy and resources, so I don't see why I should ask a question and that information be shared to another meeting. So I've got to go to another meeting now. So, but clearly, if it's not going to be asked, that's fine. I can just put a written question. Put a written question in instead. I'll get the information that way if you're not willing to cooperate, Chair. Thank you very much.
I think that's a little bit harsh. It says we're not prepared to cooperate. I think we're trying to come up with an effective resolution. Yeah.
Another question, if I may, Chair, which moves us on to different something. Delayed transfers of care. We don't have a DTOC obviously anymore. We do have admissions, discharges to routes 0 and 1. I think
That's right. Pathway 0.
That's a new indicator.
Yeah.
But we're still left, and Councillor Tilsley's touched on this, that we hear from hospitals there are 140 people waiting for discharge because there's no adequate care. But we don't have an indicator to this committee that demonstrates the, if you like, the performance of adult social care in being able to provide the places that people need. Is there any progress in getting a replacement to the measure that would have been a measure of delayed transfers?
I think Andrew Marsh did a presentation on the new measures because I think they do discharge to assess now. So assessments don't take place in hospital, they take place outside of hospital. And I think Andrew was working with the committee around the measures that they collect as a system. But I'm not sure what the outcome of that discussion was. I don't know if yourself knows, Fiona. I could see there was contact with Gail and Andrew about the measures and about discharges. But delays are often for so many reasons, hospital transport, medication, queries around fitness and whether people are fit for discharge, that it's often not social care alone. But yeah.
I think from the briefing that was given, that's what the chair reported at the beginning of the meeting. There was a subsequent meeting because Andrew wasn't able to provide all the information that members had about questions about the trust processes. So the next briefing is going to be with a colleague from the trust to be able to provide that information. So it's a bit of an ongoing process, really.
Yes, I was just raising
if there's anything I can do to help, though, do let me know, because they work as a joint service, the early intervention and hospital hub.
Chase that up with Gail to speak to Andrew about it and see where we are, and then possibly liaise with Maria about that.
Yeah.
And then to go back to Councillor Moore's question, although I appreciate he's not here at the moment, is the committee happy that we pass this to resources, or would we like the committee for Maria to actually get that information and then report back to us directly? Yeah.
Absolutely.
Yeah.
That's fine, absolutely. Yeah, I'll go through to our finance colleagues. Yeah.
I'll let Councillor Moore know that information has been requested.
Yeah.
Thank you.
Do we have any more questions for me? Councillor Pritchard.
Right one to reopen cans of worms. Just to go back to this proportion of clients reviewed, reassessed and assessed within 12 months measure, is there a plan at all to get it up other than we recruit loads of staff? And because as has been already suggested, it has been bouncing around the mid-60s now since May. And it never, even last October, which is kind of seen as the high point, it was still never actually on target, ever. And it's always been about 10% under at best. So is there a plan? And I take all the points that it's always the thing, the Cinderella that gets kind of pulled every time there's pressure on, and other things have to take priority. But is there a plan, now that staff in place, to get that measure up at least to what it was last October, but actually somewhere near what the actual target is?
Yeah, John Williams, who's the the service director for that area, has a strong performance improvement plan around reviews and sets very close targets for the community teams to improve the number of reviews that are being undertaken. That carries on to be a focus unless we hit a priority like discharges, and then we look at how we deploy resource. So there is a plan, but we still have to bear in mind that when the system is under phenomenal pressure at the moment, and if we need to move people to support the most acute services, we do. So there is a plan. It is followed through. October, probably because October is often the last month before we really start to see winter pressures hit around November, December, January, February. Although this year, to be honest, we've had that pressure all year. It really hasn't reduced the waiting list for that long.
So when then do you think you would get the figures back up to at least what they were in October 21, if not higher?
Yeah. Can I ask the service director and come back to you, Councillor Pritchard? Thank you.
I was asking by when we would see the significance or improvement in that measure, kind of what, by what month as a rough estimate, and Maria said she'd come back to us on.
Yeah, I said if I could speak to John Williams, the service director, to see what the planned trajectory is.
I think you're back again with us on committee for the March committee.
Lovely. And I think we're bringing the constituency data then as well, Councillor.
I think so. I think it would be useful. I think if you could get possibly the response to Councillor Moore's question for that meeting, that would be useful as well.
I'm sure we can find that before.
I'm sorry if I confused things earlier suggesting the resources committee, but I'm just conscious that the budget scrutiny process for next year's budget will be carried out through the resources scrutiny committee, and that committee's meeting on the 17th or the 9th, I think it's the 19th of January, to consider the budget proposals and then make any response to the executive on those proposals. So I'm just wondering if that finance information comes through and is circulated to the committee, it may mean some work in between meetings, but if there's anything that you wanted to raise to feed into that resources committee to look at the budget for next year, that I think would be the process to do it. I mean, I absolutely get that this committee can look at retrospectively at what has happened, but I think probably what members are interested in as well is actually what's going to happen next year as well.
The specific question was about this year, so yes. I think that's why I think that's fine.
Yeah.
Take the point there for next year. There's another point.
Yeah.
Okay. Do you have any more questions, members? No? Okay. Thank you for the questions and
thank you very much.
Presentation.
Thank you.
Right, the next item we got is the work programme. Does anybody have any questions on the work programme? Back here again in January, and we've got day opportunities, which is John Williams is going to feedback on the co-production report, and John Williams is also going to feedback on the adult social care reform items. So has anybody got any questions on the work programme? No? Okay.
If I could start on the inquiry, which I've just set out in the report that the work is ongoing, but just to note that there is a task and finish group quite early in January, on the 3rd of January. I know Gail's been in touch with members about that. So I just wanted to flag that there'll be that meeting early in the new year.
Okay, so date and time of the next meeting is the 24th of January 2023 at 10 o'clock. Do we have any requests for calling or council actions? Okay. Any other urgent business? No. Okay. Can I move to have an urgent situation between meetings, the chair join it with the relevant chief officer as authority to act on behalf of the committee.
Brilliant.
Can I wish you all a happy and peaceful Christmas?
And you.
And you,
Okay.
where are the mince pies?
Pardon?
Where are the mince pies?
Where are the mince pies?
Until 6 o'clock.
Still in the shop, I'm afraid.
I'm just asking